calibration.
Here we have the Edwards Life Science Visual monitor. We will be demonstrating both in vitro and in vivo calibration of the machine. Attached to each pole we have the steps for both calibration and setup, both by Edwards Life Science themselves, also giving what some of the normal ranges are for multiple different hemodynamic parameters. We will start by demonstrating the preferred calibration setup, which would be the in vitro before the line is inserted into the patient. So given enough time, we would optimally have the line calibrated before actually inserted. So this is the kit that the physician will be requesting. We will open up the kit. This is found on the central line cart. Open up the kit and find, just going to demonstrate with a used kit here. We will open up the very side only. This way we ensure the sterility of the actual line that we'll be inserting in. Coming out of here we will have a line that connects to the optical module, which should never be removed from the actual line unless needed. One example of a time when we would need to remove this would be during an MRI test, because there are magnetic metals in this module. So once we hook that up, have it attached to the back, this is all color-coded. We have the optical module, then also the SCVO2 red optical module is a black, which also needs the brains that goes into the
window.
Philips monitor system. Once that is hooked up, we are going to go to the calibration, which is our SCVO2. In vitro calibration. At this time we can enter the hemoglobin. If we do have lab values from the patient that are recently acquired, we can use those, or they also have the factory defaults. Once we enter those numbers or use the defaults, hit calibrate. It takes about 20 seconds for that to calibrate. After that time, the physician can be prepping the patient during this whole time, so there really is not any delay in line insertion. Once that time is up, it says in vitro calibration OK. Insert catheter, then select start. So at this point we don't touch anything else on the machine. The physician would have inserted the catheter. Everything is already hooked up to the optical module. We just have to ensure that sterile field is maintained. Usually the physician will have us hold the optical module so it does not interfere with their sterile field. Once the line is inserted, the physician will ask for the value. We hit start, and at this time it's going to run through and actually do the update. And then we will get a lab value. Usually about 20 seconds again.
More. Don't go up here.
At that point we can tell them the SCVO2, and then they can change the plan of care accordingly. If we do not have in vitro calibration available, if the line was already in place, say sometimes they insert these lines in the EUCC or surgery, and we're coming up and we're going to hook it up after, we would take the optical module, hook it up to the blue port that is coming off of the line, and then during that time we would go down to in vivo calibration. At this time it will also warm up the optical module, usually taking about 20 seconds.
The FlowTrack system setup process is easy because it leverages existing practices for setting up arterial lines. Connect FlowTrack to the patient monitor for standard arterial blood pressure and to the Vigileo monitor to generate advanced hemodynamic parameters. After standard arterial zeroing and simple patient personalization, FlowTrack provides hemodynamic insight through a smart algorithm that adjusts dynamically to changing patient conditions. The Vigileo monitor continuously displays and updates continuous cardiac output, cardiac index, stroke volume index, and stroke volume variation every 20 seconds when used with the FlowTrack sensor. These parameters help guide the clinician in optimizing stroke volume through precision-guided management of preload, afterload, and contractility. To provide these parameters, the algorithm begins with the premise that stroke volume, or the volume of blood produced by the ventricle with each heartbeat, is proportional to pulse pressure. We see from these references that the pulse pressure is simply the difference between systolic and diastolic pressure, and that an increase in stroke volume will be shown by an increase in pulse pressure. We also see that compliance will have an effect on pulse pressure. That is, the greater the compliance for any given stroke volume, the lesser the pulse pressure. As the cardiac cycle progresses, the arterial pulse at any site is created by an impulse generated by the left ventricle as it ejects blood into the aorta. The arterial waveform is most commonly measured from femoral or radial arteries. The morphology of the waveform will vary depending upon location. Focusing on a singular arterial waveform, the wave can be measured through the plotting of numerical data points, so as to determine whether the cardiac cycle is in systole or diastole. Pulse pressure is the difference between systolic and diastolic pressure. An increase in stroke volume will be represented by an increase in pulse pressure. For example, with a high pulse pressure, a high stroke volume would be assumed. Conversely, with a low pulse pressure, a low stroke volume would be assumed. Using the waveform generated by the arterial pressure signal, FlowTrack samples the arterial pressure at 100 Hz. Each sample is a pressure data point measured in millimeters of mercury. This data is analyzed and updated every 20 seconds, utilizing the 2,000 data points, 20 seconds by 100 Hz collected. The algorithm then performs a standard deviation calculation on these arterial pressure points. The standard deviation or quantitative assessment of these data points is proportional to pulse pressure, which is in turn proportional to the stroke volume. The result is a robust measure of stroke volume because it looks at the entire arterial waveform. Because a person's vasculature is not constant, an assessment of their vascular tone must be accounted for, as it will affect the relationship between pulse pressure and stroke volume. FlowTrack accounts for changes in vascular tone through its simple patient personalization for age, gender, and body surface area. These variables enable the algorithm to assess changes in vascular tone on a patient-specific level. Chi is a symbol for dynamic polynomial functions, a function that continuously adjusts to multiple changing variables. Depending upon the state of the patient's vasculature, the arterial waveform will take a shape that can be characterized mathematically. The statistical tools used, in addition to the aforementioned standard deviation, are the mean, skewness, and kurtosis. Mean, clinically known as MAP, can provide an indication of the increase or decrease in resistance. Skewness, or symmetry of the data, is often associated with the stiffness of the patient's vasculature. Kurtosis, a measure of how peaked or flat the data distribution is, provides an indication of the nature of vasculature as well. For example, larger vessels will typically have a flat distribution as compared to peripheral vasculature. The aortic compliance function, or the age, gender, and body surface area function within CHI, helps to provide an estimate of the patient's likely vascular tone. Further analysis of the waveform shape is also a significant factor to providing vascular tone estimates, essential to the reliable calculation of stroke volume and cardiac output without the need for manual calibration. There is a direct relationship, i.e., the shape of the trend shown above, between arterial pressure and large vessel compliance as it relates to a human's age or gender. That is, a male will typically have a more compliant aorta than a female of the same age, and a younger person will have a more compliant aorta than an elderly person. This relationship was quantified and mathematically modeled by Longwooters. As part of the assessment for vascular tone, estimates of aortic compliance based on the above principles are important but not all-encompassing. Therefore, in addition to Longwooters' mathematical model, further waveform analysis is conducted by the algorithm to take into account patient-specific, real-time effects of vascular tone on the waveform. The result is a robust measure of stroke volume, because all measurements are patient-specific, reflect shifts in vascular tone, and are real-time. CHI also includes several advanced physiologic-based variables, such as pulsatility, which recognize and then compensate for many hyperdynamic patient conditions. By utilizing these empirical data relationships established during the development of the algorithm, the system is able to correlate pressure calculations with stroke volume without requiring a manual process of calibration. For example, thermodilution, lithium dilution washout curve, and remains accurate when changes in tone occur. Other pulse contour or pulse power-based technologies require a dilution washout curve to provide a calibration constant, compensating for these algorithms' ability to independently assess the ever-changing effects of vascular tone on stroke volume. Cardiac output is calculated by multiplying heart rate times stroke volume. The FlowTrack algorithm calculates stroke volume by multiplying the standard deviation of the arterial pressure SDAP signal against CHI. Pulse rate is calculated from the arterial pressure signal. When stroke volume is multiplied by heart rate, which is measured by the pulse rate that is computed from 20-second time period of beats, the result is cardiac output. Preload responsiveness is the determination of whether a patient will respond with increased stroke volume when given additional volume. Since traditional parameters are poor indicators of preload responsiveness, a specific and sensitive indicator is needed to guide volume resuscitation. The elements of stroke volume are preload, afterload, and contractility. Treatment of preload is the most common intervention, but none of these traditional parameters evaluate preload responsiveness. An effective way to evaluate preload responsiveness is through the parameter stroke volume variation. As a dynamic parameter, stroke volume variation has the advantage of predicting whether a patient will benefit from fluid volume before the volume is administered. This study demonstrates that SVV has a high sensitivity and specificity in determining if a patient will respond by increasing the patient's stroke volume when giving additional volume. This is referred to as preload responsiveness. The ROC curve demonstrated here describes the incidence of false negatives and false positives as compared to traditional parameters. The higher area under the curve number, the more sensitive or specific predictor of preload responsiveness. In a normal individual who is breathing spontaneously, blood pressure decreases on inspiration. The range of normal peak decreases in systolic pressure have been reported between 5 to 10 millimeters of mercury. The exaggeration of this phenomenon, called pulsus paradoxus, can be described as a pulse disappearing during inspiration and returning during expiration, despite the continued presence of the cardiac activity during both respiratory phases. Mechanical ventilation induces cyclic changes in vena cava blood flow, pulmonary artery blood flow, and aortic blood flow. At the bedside, respiratory changes in aortic blood flow are reflected by swings in blood pressure, whose magnitude is highly dependent on volume status. These swings, when measured as a percentage, are an indicator for preload responsiveness. The above equation is the conventional method by which SVV is calculated during mechanical ventilation. The difference between the maximum and minimum stroke volumes within a given time are divided by the mean of the maximum and minimum stroke volumes. The SVV is displayed as a percent value. SVV values used to guide preload responsiveness have varied between 10 and 15%. In healthy patients undergoing neurosurgery, an SVV value of 9.5% was found to predict a positive increase in stroke volume in response to only 100 milliliters of plasma expander with a 79% sensitivity and 93% specificity. The FlowTrack volume responsive algorithm can be used to determine if a patient should be administered fluid or another agent, such as an inotrope. Here is an example of SVV's effectiveness at predicting fluid responders. The above case is an exploratory laparotomy with tumor removal. The FlowTrack sensor was used in addition to traditional vital signs. The patient experienced a sudden loss of blood during the procedure and was volume resuscitated, packed red blood cells, and normal saline. SVV was used as a guide for starting and stopping volume resuscitation at the points shown by the arrows. The following screens demonstrate the patient's response to resuscitation at the point highlighted by the second arrow above. With an SVV of 19% and stroke volume of 45 milliliters per beat, the patient received 1 unit of packed red blood cells and 500 milliliters normal saline. After resuscitation, the SVV decreased to between 9 and 6%, with a stroke volume increase to approximately 60 milliliters per beat. One aberrant reading of 25% was due to arrhythmias. As displayed in the numerical trend screen, the graphical trend screen also shows an increase in cardiac output in response to volume resuscitation. Although a powerful tool managing your patient's volume resuscitation, SVV has limitations. Mechanical ventilation. Current literature supports the use of SVV on patients who are 100% mechanically, control mode ventilated with tidal volumes of more than 8 cc per kilogram and fixed respiratory rates. Spontaneous ventilation. Currently, literature does not support the use of SVV with patients who are spontaneously breathing. Spontaneous breaths use negative pressure ventilation with small, varying tidal volumes. Arrhythmias. Arrhythmias can dramatically affect SVV. Thus, SVV's utility as a guide for volume resuscitation is greatest in the absence of arrhythmias. Clinicians understand the vital role of fluid balance in critically ill patients. Too much fluid can result in edema, respiratory insufficiency, or acute coronary syndrome, while too little fluid can place a patient at risk for circulatory disturbances, shock, or pre-renal failure. Some patients who would benefit from fluid receive too much inotropic support, which can result in tachycardia or other complications. Successful fluid optimization has been shown in numerous clinical studies to lead to improved patient outcomes, including reduced morbidity and shorter hospital stays. The studies are typically based on the physiological principles outlined by the Frank-Starling curve, which states that an increase in preload or volume will lead to cardiac flow-related improvement up to a certain point, after which the principle of diminishing returns applies. The FlowTrack system equips clinicians with a set of tools to assess both dimensions of the Frank-Starling curve. First, FlowTrack's algorithm utilizes advanced waveform processing to adjust dynamically for vascular tone, resistance, and compliance, in addition to patient-specific variables, age, gender, body surface area, etc., in order to calculate key flow-related parameters, stroke volume, and cardiac output. The result is an enhanced ability to determine the adequacy of cardiac flow, which comprises the y-axis of the Frank-Starling curve. Second, the FlowTrack system measures preload responsiveness for the x-axis of the Frank-Starling curve through one of three distinct practical methods. Stroke volume variation, SVV, has been proven to be a highly sensitive and specific indicator for preload responsiveness. As a dynamic parameter, SVV has the advantage of predicting whether a patient will benefit from volume before the fluid is given. In situations where it is not possible to use SVV, the effects of fluid loading can be replicated by using passive leg raising. FlowTrack not only proves useful in continuous SVV monitoring, but also has the ability to calculate delta changes with self-volume or real volume challenges. Passive leg raising is a simple bedside maneuver that can demonstrate whether a patient is preload responsive through a self-volume challenge